Hey, everybody, it's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways. There's another bad habit that I certainly have fallen into the trap of, and that is when you can't get a good view, or you think you have a good view, and then you go to deliver the tube, and you're just like, wow, it seems like it goes wherever.
Then you go right back at it without making any adjustments.
So well, I mean, you're bringing up a great point, right? If thing one didn't work, change something.
Don't do thing one again.
Yeah, change something, right? Einstein's definition of insanity, right? And same thing over and over, expecting different results, right? But I really wanted to talk about visual acuity, right? So, to have depth perception, you have to have both eyes focused on something, right? And what do we do when we're having a hard time getting a tube in? We instinctively get closer and closer and closer and closer to it. And what you're doing is you're taking away your depth perception the closer you cram into it, trying to see better. You're actually counterintuitively making it more difficult to figure out where. And it's a real simple test. I mean, where's your focal point, right? Just put your finger in front of your, and move it back and forth until you see.
Here. And it's getting further away every year.
Right. But if I'm there, I can probably still figure the depth perception out. But if I cram in closer, I'm actually doing a disservice to myself and my patient, right? And if you've never done that, it's just like you advance the tube and it's just like you think it's going to go in, and it misses completely. And you're like, how does that happen, right? Yeah. It doesn't even make sense. That's because you're only seeing 50% of the picture because you've crammed in so close. It'll be whatever your dominant eye is. Okay, in my case, it's my right eye. So I would only see this side, right?
I think tube sizing is very important. Make sure you get the right tube.
And the bigger the better.
The bigger the better, especially
size does matter in this case.
This obviously 6.0 tube is not big enough for this patient.
Correct.
The distal cuff pressure is going to be very important. And I actually, before this, I did a little looking. 60 to 80% of the time, pre-hospitally, the tube pressure is incorrect, which is huge. So 20 to 30 centimeters of water should be where it's at. And there are devices out there commercially to buy that will.
I don't know if that.
We got another one.
I think there's a hole in that balloon.
Oh yeah, I threw
we
it
got
out.
another one.
This is a new one.
Yeah. So the bad EMS habit is what?
Give it all.
Slam
it.
it.
You slam it and undo it, right? And then this is rock hard.
Right. The concept, we talked about this with Dr. Yaski when she was on with the PEDS cuffs, but it applies to the adults as well. Is cuff to seal. How much do you put in? You put in until it seals up. Does that have to be the full? I mean, here, I put in 5.5 mLs. I mean, assuming that was a properly sized airway for my patient, that would absolutely seal up in the trachea, right? And there's more than enough. There's not much give there. This is pliable yet not rock hard, right? Like I said, I put 5.5 mLs in there. So some of that is kind of touch and feel, and there. See, I put that on, and it didn't even push back much. So, yeah.
And there are some studies that I've read out there for EMS that if you don't have a device, you can always fill quite a bit, release that for a second, see where it comes out to, and then unscrew it, and that's about right.
That's about right.
But always, it's really not a lot of pressure when you think about it.
No, you don't want to hyperinflate it and cause any type of trauma or ischemia due to that, or hyperinflation of the cuff.
Tracheal ischemia, yep.
And there's an easy fix that if you've given too little, you're going to hear some squeaking or hear air coming around the tube. Yeah. Give it a little more.
We drive respiratory nuts because we're just, what's the answer? 10. No, the answer is not 10, right?
But then we're taking it off and screwing it back on with 10 more.
Yeah. The answer isn't 10. The answer is enough to seal it up, and that should be the default answer, even though sadly I think a lot of times it's not. What's one of the first things, not the first thing that they do when respiratory does when they
They should squeeze that and determine how much is in.
Well, they come along with a gauge, with a cuffulator, and they see what those pressures are. There is a device, I didn't bring it with me, but there is a digital device. It's a 10 ml syringe that will give you a readout of what that pressure is.
20 to 30 is where we should be.
Yeah. So.
And I thought it was amazing that 60 to 80% of the time our cuff pressures aren't wrong. Like we had discussed earlier, I thought it'd be higher.
I figured it would be higher. Yeah.
Maybe it's not done a good job of educating you guys.
Maybe somebody did, yeah. I don't know where that study was done at, but that was the post-education resurvey, right?
Yeah, exactly.
And then there are different types of endotracheal tubes, right? Some can have very fancy. I know there's one that has basically a piece of fishing line in here with a little ring that you can, manipulate that tip if that's something that your agency's invested in. The ones we've been buying as of late all come preloaded with stylets, and whether you love or hate a stylet, I think it is super convenient to have it there, right? And then just dump it if you're not a stylet person. When these get used, and I've given some caution to people over the years, if you wind up using these to do like a surgical crike or something, obviously it's only going to go in about that far. A lot's going to be hanging out. People want to trim these down, depending on the brand you buy and how they're made. Cutting this channel that this air line goes into may actually leak on this end. So it's just, you're not going to know. You're not that good. Just don't cut it.
Not only that, but this is really hard to push back into the cut tube.
Also, yes.
Unless you have a cigarette lighter, which you probably shouldn't be doing.
All of that is completely unnecessary for what we're trying to accomplish, right?
And when I teach crikes, I just say leave it.
Leave it long.
Leave it long, tape it to the patient, move on.
Yep, wrap it around her head a couple times, and you're good. Yep.
Yeah, you can tape it around their mouth. I think the myth of going past 25 is not allowed is BS. I think that people's anatomies are different. You have people who should second their life as a giraffe, very long necks. You might go past 25 to get it right. So do what's right for the patient, not just because you hit a number. Again,
it should be based on your visualization of passing the tube through the cord. There's actually an indicator on the tube that most people usually disregard.
Ignore, yeah.
They just see it and they're like, then they bury it. And I think that's kind of where that mantra came from. But I think if you have good direct visualization and you watch it go through the cords, as soon as you lose the black ring around it, then you should know, I need to stop and then hold on to that tube.
If you're hitting the carina, you've gone too far.
Yes.
And if you did go too far, you're probably on the right.
You're probably not going to hit the carina. You're going to deviate to the right.
To the right side, yeah.
You're right. So which is also important to know your anatomy. I mean, the carina there is at the angle of Louis, or Lewis. And if you've gone too far, you've passed that.
And, I mean, there's a really quick and easy way to tell if you're too deep, right?
Listen to lung sounds.
Yep. You can see if you did a right main stem or not.
Yep. So I earlier was talking about my personal affinity for just a routine hockey stick, and that is what a hockey stick looks like, right?
Maybe to you.
But what does a hockey stick look like to John Hill?
So I do start hockey stick, right? If I can, but that's my hockey stick. And if I can't, and if I need more, I will go U-shaped. But this is when I get into the airway, it gets turned into a hockey stick, but I can make it get a little more anterior with it, which is why I will sometimes do that. But you can also ask your partner to put
cricoid
pressure down to help you out for those very anterior airways that you can't get into.
We used to say that we got rid of that method called burp, but I still think it's warranted in some cases, the backward, upward, rightward pressure here.
Yep.
So.
The one thing I wanted to make sure we dispel, but we clarify is you talked about adding cricothyroid pressure, and remember that AHA came out and said no routine use of that as part of your airway management. That was not intended to help
Don't do it.
one time, right?
Yeah.
Routine use is not necessary. Don't do it,
Don't
right?
do it.
Is if you need to get it, get that view.
Little more,
If
yeah.
I need to
more,
just
you're
move it down a millimeter
absolutely-
just to be able to get my ET tube up
where I
into
need it to
the-
be,
Yeah.
That's okay.
absolutely appropriate, absolutely okay for that to happen. So you're not breaking a rule. You're not, and it's important for the next person to know, hey, it took us a little crank pressure to get the view we needed, right? Because if you have to re-intubate them, or if, they come off sedation, badness happens, tube goes across the room, whatever. Things happen, right?